My name is Michaela Lewis. I am in Professor Finch's medical terminology class, and I am doing a course project on endometriosis. To begin, the female reproductive system includes the vagina, cervix, uterus, ovaries, ovarian ligaments, fallopian tubes, fimbriae, peritoneum, and peritoneal sidewalls, the rectum, anus, and many more areas in which can be affected by endometriosis and other diseases of the reproductive system. Endometriosis is one of those many diseases and disorders that affect the female reproductive system, and is, according to Mayo Clinic, is defined as an often painful disorder in which tissue similar to the tissue that normally lines the inside of your uterus, the endometrium, grows outside of your uterus. And with endometriosis, the endometrial-like tissue acts as an endometrial tissue would. It thickens, breaks down, and bleeds with each menstrual cycle. But because the tissue has no way to exit your body, it becomes trapped. When endometriosis involves the ovaries, cysts called endometriomas may form. Surrounding tissue can become irritated, eventually developing scar tissue and adhesions, which are abnormal bands of fibrous tissue that can cause pelvic tissues and organs to stick to each other. Endometriosis.org notes that endometriosis affects an estimated 1 in 10 women during their reproductive years, usually between the ages of 15 and 49, which is approximately 176 million women in the world. This means if you were standing in a room with 9 other women, including yourself, one of those women unfortunately is plagued by this disease. I am one of those 1 in 10 women, and have been battling endometriosis since I was around 9 years old, much earlier than the projected time of menarche or the start of a menstrual cycle, and I am still suffering daily at the age of 22. As someone who has suffered firsthand with this disease, I have learned more than the average person would know, sans medical degree, about this disease. Firsthand, I have dealt with adhesions or severe pelvic congestion, my uterus being stuck to my bowels, my ovaries being attached to the retroperitoneal sidewalls, causing severe pain. And not only that, I have been plagued with dysmenorrhea, vaginismus, menorrhagia, cysts, blood clots, month-long cycles, emesis and nausea, gastrointestinal symptoms like diarrhea or rectal bleeding, weight gain and weight loss, dyspareunia, and varying forms of mental anguish that come with years of suffering, along with depression, anxiety, post-traumatic stress disorder, and panic attacks, as well as infertility, quite literally, with the result of a hysterectomy at the age of 21 due to adenomyosis, fibroids, polyps, pustules that never healed from prior surgeries, and more. Yet the list of symptoms is even longer than what I have personally faced myself for other women. There has always been speculation as to who first found or correctly diagnosed endometriosis for the very first time. This was touched on by Giuseppe Benagiano and Ivo Brozins, both doctors from the Department of Gynecology and Obstetrics from Sapienza University of Rome. These two doctors explained that a vivid example is found in the book The Adenomyoma of the Uterus, published in 1908 by Thomas Cullen, MD. In describing for the first time the symptoms of uterine adenomyomas, he wrote, "In the early years of our investigations, we also failed to detect it clinically. But in the early and fairly advanced stages of the process, so definite are the symptoms that the hospital assistant now frequently comes and says that a given case has all the signs of an adenomyoma, and that he feels sure that this is the cause of the bleeding." This essentially means this could be the very first individual to clinically diagnose endometriosis and would be the foreground for all medical advancements to come in the future and try to give women who are fighting this disease a fair chance at a normal, pain-free life. Endometriosis today is usually studied by reproductive endocrinologists, gynecologists, fertility specialists, obstetricians, urogynecologists, or pelvic floor specialists. There are numerous clinics around the world that specialize in the treatment of endometriosis, and there are many different types of treatment for endometriosis, but results yield only temporary relief, especially if you do not go to a highly qualified specialist who is familiar with the size, shape, color, and scaled nature of the disease, and how it can affect various other parts of the body, not limited to the pelvis, but also the abdomen, anus, rectum, bowels, bladder, and even in rare instances, the lungs, heart, and brain. Touching further on specialists for endometriosis and other reproductive system affecting diseases, there are many specialists in the United States. Some common names mentioned at the summits for reproductive medicine or within the American College of Obstetricians and Gynecologists are the Center for Endometriosis Care in Atlanta, Georgia with Dr. Sinervo, Jacksonville Center for Reproductive Medicine with Dr. Fox, Lapari, Pascal, and team, Dr. Tamir II in New York, who is the founder of the American Foundation for Endometriosis, and Dr. Andrew Cook at the Health and Wellness Institute in Los Angeles, California. The list doesn't even touch on the top specialists that are at Mayo Clinic, Johns Hopkins, Cedars-Sinai Medical Center, or across the globe outside of the United States. All of these doctors have one thing in common, though, their unwavering dedication to finding a cure for endometriosis. With that drive and passion for this, these doctors have united on multiple fronts to push for more funding for endometriosis research. Because the EndoFund organization reported that the U.S. House of Representatives just approved doubling funding from $13 million in 2019 to $26 million for the fiscal year beginning October 1st of 2020. These surgeons, through research, clinical trials, and observations, have found that widespread excision is the best chance of removal, with the lowest account of reoccurrence of endometriosis and its counterparts, such as fibroids, polyps, adenomyosis, and cysts. These reproductive endocrinologists usually do laparoscopic excision through widespread peritoneal excision, through little incisions made into the abdomen and the bikini line, addressing the bladder, uterus, ovaries, fallopian tubes, and areas that lesions are sometimes hidden, such as behind the ovaries, the pouch of Douglas, round ligaments near the uterus, rectovaginal septum, and underneath the bladder neck. Endometriosis has always been diagnosed and dealt with in terms of stages. This means that according to the Endometriosis Foundation of America, that the American Society of Reproductive Medicine bases these stages on lesions themselves, particularly the number of endometrial implants and their depth. However, the ASRM revised their classification to include a point system. This point system allows for a way to numerically scale the disease and help determine classification. A score of 15 or less indicates minimal or mild disease, and 16 or higher indicates moderate or severe disease. It is important to note that the stage of disease does not reflect the level of pain or presence of symptoms. To touch further on this, as I mentioned, reproductive endocrinologists, fertility specialists, and the excision specialists for endometriosis are familiar with the color, sizes, and shapes of the lesions, and have a trained eye to be assured they get as much of the disease as they can during surgery to hope for the best outcome post-operatively. These lesions can be anywhere from pin-sized to dime-sized and can be clear, white, yellow, red, blue, black, or brown in color. Dr. Tamir II created a technique outlined in his book, The Doctor Will See You Now, called ABC, or aqua blue contrast, which he notes the solution enhances the visibility of lesions that are difficult to see due to intense brightness at a laparoscope light source. We often compare our use of the contrast to that of stars in the sky. During the day, these stars are not seen, even though they are still present. However, when the sun's light disappears in the night, the stars are revealed. Similarly, our contrast is the same to eliminate laparoscopic glare, allowing the surgeon to discern endometriosis lesions not visible to the naked eye. Because of this, endometriosis that would go undetected during normal laparoscopic surgery can be identified and removed, allowing patients to see drastic results with symptom relief and lowering chances of further endometriosis development. There are varying other options aside from laparoscopic excision that can be done in a multidisciplinary approach to treat the pain associated with endometriosis and other reproductive issues. For myself personally, I have had a presacral neurectomy where they severed a nerve to dull pain, and when multiple hysteroscopies and dilation and cortages under anesthesia failed to remove massive amounts of endometrial hyperplasia, and intrauterine devices like Helena and Marina failed to suppress my symptoms and recurrence, along with adenomyosis, I had to involve other departments besides gynecology. I've been passed specialist to specialist and had far too many surgeries in an attempt to get relief. I've seen the top minds of medicine specifically for gynecology, like the names and clinics mentioned previously, but I unfortunately had regrowth or reoccurrence with each surgery. When gastroenterology was involved, I had multiple procedures to look for ulterior reasons for my pain, and multiple colonoscopies, endoscopies, tricyclic antidepressants like Prozac or amitriptyline to help with the chronic pain aspect, diet changes like low-carb, wheat-free, dairy-free, gluten-free, etc., and saw nutritionists and allergists as well. When it was found that I had bowel involvement, I immediately had excision with a colorectal surgeon to address rectal bleeding from the lesions that bled during my cycles. And when urology was involved, I did a myriad of testing as well. including a cystoscopy with hydrodistension, urinalysis, and through these tests it was found that I had several large lesions in my bladder and was told to try anti-inflammatory diets for interstitial cystitis and medications like benazopyridium, mibetriq, and belladonna suppositories to help with dysuria, incontinence, and nocturia. Not only does bringing in outside care address other issues related to endometriosis, proving beneficial, it can help improve the overall standard of care for greater relief of symptoms and impact to daily life. I saw pain management during my battle because a huge part of the pain is mental anguish that comes along with the diagnosis. You can feel hopeless, overwhelmed, anxious. Anytime you have new symptoms or repeat symptoms, medical-related PTSD from years of crippling pain and taxing effects of surgery and cyclical recovery, and feeling severely depressed and having a wavering feeling of things never changing. You're never getting better and pain defining you. That is why it is crucial to see licensed mental health professionals, whether that may be psychologists, psychiatrists, or counselors, to provide relief from the crippling mental anguish that comes from a disease that causes crippling pain, embarrassing moments of bleeding through clothes, sheets, inability to have intercourse because of how painful it is, or never getting concrete answers or a permanent fix that is gratuitous in that moment. It can be very hard to break this cycle of catastrophizing your existence and diagnosis and feeling like there's no way out. Bringing you to my final point and wrapping up my culmination of information about endometriosis, ensuring you have a multidisciplinary approach to treatment will yield the longest lasting, most effective results in terms of relief. If you couple excision surgery with the best specialists working together from different subspecialties and bring medication for depression, and also for suppression of endometriosis like progestin to inhibit heavy bleeding and shorten menstrual cycle are good jumping off points for treatment. Add in pelvic floor therapy, and that's another excellent option to try to help dyspareunia and vaginismus and loosen the tight, constantly cramping muscles from dysmenorrhea. Doing research is another crucial point because it ensures that you're well versed in what specialists are local and who are accepting new patients and finding out what they do specialize in and what do not specialize in. You can also use the internet as a resource to find support outside of mental health with regards to support groups that are filled with women who have dealt with the same things as you have faced to help you feel less alone and to find ways in which individuals are dealing with various facets of this disease and maybe can bring new ideas to mention to your physicians for a treatment plan for yourself, like maybe new drugs like Orlissa, the use of a TENS unit to deliver electrical bursts to the area that is hurting, to redirect nerve impulses sent from the brain meant to trigger pain responses, or maybe ice and heat therapy. You can also use the library or online resources to understand potential diagnoses or medical terms that can seem foreboding, such as adenomyosis, what a fimbrioplasty is, what in vitro fertilization entails, or what a salpingo-oophorectomy is done for during the hysterectomy. It is crucial that I myself and other women never lose the fire within themselves to push for a higher standard of care, a definitive cure, and answers for their pain and total understanding as to why their bodies are inadvertently failing them. It is imperative to ask questions, be your best advocate for your health and others, in the hope that one day endometriosis will be easily cured and understood by all medical professionals alike. Here is a list of the medical terms I used in my paper associated with endometriosis, kind of listed in order in which they were mentioned. And my work cited is on this PowerPoint and also inside of my actual document. Thank you.